Hey folks, hope you're having a great day today. We're going to do the first part of chapter 20 today. I'm going to cut this chapter into two parts so that it's a little more digestible. So first off, chapter 20 is our last chapter in the cardiovascular system. Chapter 20 is blood vessels. So let's go ahead and kind of get into the chapter. Don't forget that we've got three types of blood vessels, and we've mentioned this already. The first type of vessels are arteries. These guys leave the heart and take blood away from the heart and towards the capillaries. Capillaries are the exchange vessels. This is the only place that things can get in and out of the bloodstream. And then we come back from those capillaries to the heart through veins. Remember, we talked about the different circuits of. And so, sometimes we're heading to capillaries in the lungs in the pulmonary circuit, and then other times we're heading to capillaries that supply the rest of the cells of the body. They're in the systemic circuit, but no matter what, we've got to come back to the heart in order to be pumped into the other circuit. And so we continue this flow of these vessels. Here's kind of a image showing us the difference between an artery here and a vein here. So arteries and veins tend to be side by side, and we call them companion vessels when we see them side by side. And here we can see that the artery is much smaller compared to the vein. The artery wall actually has more muscle in it. You can't tell, but that darker color purple is more muscle compared to very little dark purple at all in this vein. And so there's going to be some differences between arteries and veins that we're going to talk about here. Here they're hiding that vein. Let's just move forward. Again, when we talk about these vessels, there's going to be some similarities, though, between the two. So we will see some similarities in the vessel walls, that there tends to be three vessel walls in most arteries and most veins. And as we become smaller arteries and smaller veins, we start to lose those walls. And whenever we're capillaries, we tend to only have one of those walls, one of these tunics. So we tend to have three layers of the vessel wall, and we also refer to these as tunics. The inside of the vessel where the blood is flowing is referred to as the lumen, and we've used that term before to talk about the inside of any hollow structure is referred to as the lumen. Three layers: tunica intima or tunica interna, the tunica media, and then the tunica externa are the three main layers. So let's just kind of get into it and talk about it a little bit. The tunica intima or the tunica interna is the innermost layer. This is simply an endothelial tube. So we say that term a lot. This just means it's basically simple squamous epi, and it's just coiled over on itself to form a tube. And so this is really kind of the same thing as the endocardium, but here we're going to refer to it as the endothelium in a blood vessel instead. This again is the layer, the lining that the blood is actually touching. The middle layer, the tunica media, has the muscle in it. So it has smooth muscle in there in order to control the flow through that tube, to control vasoconstriction and vasodilation, to constrict that muscle, to trigger that muscle causes vasoconstriction, and then to kind of inhibit that muscle causes vasodilation. This can open and close that tube to control the blood flow. And we're going to find out that's the most important way that we can control flow through the body is by controlling that vasoconstriction and vasodilation. The tunica externa is the outermost layer of the blood vessel, and really this is kind of just an outer protective layer. It helps anchor the vessel in place compared to the other structures that are surrounding it. So I don't care if you know the term vasa vasorum. I'm going to just not worry about that. So here we can kind of see, here's an artery, we've got our tunica intima, we've got our tunica media, and then we've got our tunica externa. Again, the intima is what the blood is touching. The media is where we see a lot of that smooth muscle that's going to be important for vasoconstriction, and that's mainly in arteries, because I mentioned that. Here we can see it in veins. We don't have as much smooth muscle. So as a result, we're really going to see that vasoconstriction more in the arteries compared to the veins. Something that we notice that I've already pointed out was the size of the vessel. The arteries, the inside, the lumen is much smaller compared to a vein. And here's something else that we haven't talked about yet. Veins are going to have valves. In order to get blood to flow from the heart back to the heart, blood must go downhill in pressure. And so once we get to the veins, we're starting to hit an area of lower pressure. So blood likes to pool there. And instead of allowing it to pool we're going to use these valves, and then we're going to assist with muscles. So for example, in your legs, blood likes to pull down towards your toes because the blood pressure is not great enough to overcome gravity. So as a result, we have these valves, and then we can just squeeze up above a valve, and then that prevents that backflow, prevents the pooling overall. And that's something that we're about to do right here, is compare these two vessels. Again, as I mentioned, arteries and veins tend to be side by side. They tend to supply and leave from the same region, so we call them companion vessels. If we compare two companion vessels, the arteries, again, are going to have a thicker tunica media, and so that means that they've got more smooth muscle, and they also have more elastic fibers. And this is important. I want you to go ahead and make a note that arteries have two main characteristics. They are elastic and they are contractile. Okay, so they can stretch and they can squeeze, right, in that tunica media with that smooth muscle. And so we're going to see some differences here due to that. We don't see veins stretching. Okay, we have arteries stretching because of high pressure. And then we don't see veins controlling blood flow because they're simply trying to drain that blood back to the heart as quick as they can. The arteries are trying to control blood flow with this constriction in order to make sure the active tissues get more blood than the less active tissues. And so we're going to start to see that that's a main kind of function of these arteries, is to control the flow to the capillaries and then also be able to take the extra pressure that's made by the heart. Okay. Again, the lumen is narrower in an artery compared to a vein. When we're looking at veins, they have a thicker externa and they have a larger lumen. So they tend to have more blood in the vein compared to the artery. So we're going to find out that most of the blood in your body at any one point in time tends to be in the veins. In your veins. And again, there's really no elastic hardly at all, and there's no smooth muscle hardly at all. Okay. Capillaries, again, it's only the innermost layer. It's only a tunica intima. It's only an endothelial tube. It's really just endothelium with its basement membrane holding it intact. Anytime we talk capillaries, we connect to the word exchange, gas, nutrients, waste, good, bad stuff to the cells, from the cells. That's what we're really looking at. Here's what we're about to talk about during this component of the recording, and then we'll switch over and talk about a little bit more complicated things in our next recording, kind of the second half of chapter 20. Start with the arteries. We're going to go through elastic arteries, and then muscular or distribution arteries, and then to arterioles, and finally become capillaries. We've got three different types of capillaries we're going to talk about. Then we become the smallest veins, which are called venules, and then we get larger to small and medium-sized veins, and eventually to the largest veins as we come back to the heart. So that's kind of what we're about to hit here as we discuss this. Let's start with arteries. Arteries branch into smaller and smaller vessels as we go farther from the heart, and as we go farther from the heart, we're going to lose elastic. So as we go from the elastic arteries through the muscular and into the arterioles, then we're going to end up losing a lot of that elastic fiber. And so see, most of the stretching needs to take place closer to the heart, and then the closer to the heart, we need to take all that extra pressure, be able to stretch, and then in between the beat, send that blood through that vessel and keep that blood flowing at all. Okay. As we get smaller, we're going to seem like we get more smooth muscle, but we're actually we have more smooth muscle compared to the rest of the layers in our arterial walls. Here's our three as we go from the heart: elastic, muscular, and arterioles, as we've already talked about. So let's mention these. Elastic arteries are the largest arteries. They tend to be connected to the heart and the major branches off of these larger vessels. So we're talking things like the pulmonary trunks, the pulmonary arteries, the aorta, common carotids, the common iliac. So these are some of our larger arteries. And these guys, again, need to stretch to take the extra pressure during that contraction. And then in between beats, they're going to recoil to keep that blood flowing at all times. Blood doesn't stop in your body in between beats. Muscular arteries are what comes next. We get smaller and smaller and smaller, and then we become these muscular arteries. These are also called distribution arteries. These guys are the number one type of arteries, or medium arteries. These are the ones that distribute blood to your organs and your muscles. And so a lot of the ones that we're going to talk about in lab, things like the renal artery, the hepatic artery, these things named after specific organs, these are going to be good examples of muscular arteries, okay? Now, as we get smaller and smaller, we're going to go from the muscular arteries and we're going to become the arterioles. So here it's mentioning that the muscular arteries, the elastic, I'm not too concerned about this. I simply want you to know that these are the more common. They're also called distribution or medium-sized arteries. And again, they tend to go to organs and muscles. Now, again, as we get smaller and smaller, we become these arterioles. And arterioles are the smallest arteries, and these guys are going to feed into the capillaries. Now, the whole key, as we go through the arterioles and as we get smaller through the arterioles, we're going to see that they start to lose their layers. Again, the capillary is only the innermost layer, just that tunica intima. And so the whole goal is as we become the capillaries, we need to shed those outer two layers. We need to drop off the externa and drop off that tunica media. And so the larger arterioles tend to have all three tunics, but as we get smaller and smaller, we end up with just that endothelial layer overall. Okay, towards the end of the arterioles, we've got endothelial with a little bit of smooth muscle. But once we lose that smooth muscle, we're going to become a capillary, because a capillary is just that endothelium tube, and it's important for exchange. So we'll talk about that here in just a second. Arterioles, I don't really care if you know this term vasomotor tone, but arterioles really kind of regulate the blood flow into capillaries. And so these are kind of the main things that do a lot of the constriction and the dilation in order to feed specific tissues, to give the active tissues more blood and to take it away from the less active tissues. And so these guys tend to be the main regulators of blood pressure and blood flow in order to make sure that the important stuff gets what they need. Here's some examples. You can look at these in the textbook. I'm not going to put this on the test. All right, let's talk about a disorder real quick dealing with the arteries, and this is arteriosclerosis. So arteriosclerosis is the big overall category. Arteriosclerosis is thickening and toughening of an arterial wall, an artery wall. We can kind of subdivide that into two main forms. We have focal calcification, and focal calcification is, you can see it right here, due to calcium deposits. The wall gets thick and tough due to calcium deposits. Calcium invades the vessel wall, compromising its ability to stretch. These now brittle arteries are more prone to rupture, and these ruptured vessels lead to gangrene, or they could lead to amputation. The point is that a ruptured vessel can't be replaced, and now you need to actually cut that component of the body off, and that's definitely not a good thing. We see focal calcification many times as a result of diabetes. And so diabetes, people who have diabetes many times have a lot less activity and a lot less movement. And so if a person with diabetes tends to just sit still and sit in a chair all day, then their blood flow starts to become a problem, because they're not really helping that blood come back from the lower legs. And as a result, there could be some calcification that starts to happen in that vessel. And then that vessel ruptures, and now that diabetic has to amputate that foot or maybe that toe, something like that. So maybe you've heard of that before. And this is the reason why. This is the number one reason for non-traumatic amputation, right? A traumatic amputation would be some sort of accident, but this is non-traumatic, and this is the main reason for amputations that don't have to do with some sort of accident. Atherosclerosis is the main type that we discuss. Athero refers to fat. So atherosclerosis is due to fat deposits, and these fat deposits, they thicken up not only tunica intima but the tunica media. We start to see some of our macrophages coming in trying to eat this fat, and then they start to get this foamy appearance, and then they start to get stuck in the vessel wall, and they start to foam in that vessel wall a little bit, and they thicken that vessel wall up. The big problem is now that atheroma, that plaque, that fat, is now sticking out into the lumen. So it's sticking out into the passageway where the blood wants to flow, and now we're slowing blood flow down. So this is definitely not a good thing. If we slow blood flow down too much, then we don't get blood flow downstream and tissues start to die. So this is what happens in many coronary arteries, right? So we hear of coronary artery disease that causes heart attacks. So atherosclerosis, people eat too many McDonald's cheeseburgers, and then that fat gets deposited into those blood vessels. Once that fat gets deposited, if we start to get platelets and fibrinogens involved with clotting, then that becomes permanent. Now you have a serious situation. Instead of being able to maybe use a stent to blow that thing up, now you're going to have a bypass surgery in order to cut a vessel out of your leg and then bypass that region of that. So definitely not a good thing. This again leads to one of the #1 causes of death in the United States due to heart attack, due to cardiovascular disorder. Okay, definitely not a good thing. Watch that fat content, make sure that you are watching the cholesterol levels in your blood. And again, cholesterol tends to come from meat, and especially certain types of meat have higher cholesterol levels. So you got to be careful with those cholesterols and eating too much meat overall. Males tend to be more affected than females. Smoking and high blood pressure tend to increase this process. And so definitely not a good thing. As I mentioned, an angioplasty, where you can take a balloon basically and put it into the vessel and expand it to try to get it back to a larger size. If that doesn't work, then again, a bypass surgery may be needed. An aneurysm is another type of a pathophysiological disorder dealing with arteries. An aneurysm is where the arterial wall kind of balloons out. I know when I was a kid, I used to blow up a balloon, and then I'd take my hands and I'd make like a circle with my thumbs and my pointy fingers, and I'd grab that balloon and I'd try to squeeze that balloon and make a little mini balloon pop out in that circle that my fingers are making. And so if you've ever done that, then you know that that section of that balloon is now weaker than every other section of that balloon. So that's kind of the exact same thing that happens with this aneurysm. If there's a little ballooning that takes place in this blood vessel, in this artery, then just like with that balloon, if you squeeze it too tight, it's going to pop, right? So now that wall is more prone to rupture. So, high pressure comes along and massive internal bleeding starts to happen, and that can lead to death. So definitely not a good thing. Aneurysms increase with age. The risk factors increase with age. So definitely not a good thing to deal with an aneurysm. Here's an aneurysm in the abdominal aorta. You can see it kind of bulging out on the side. They pointed out right there as well. Definitely not a good thing. Let's move on and talk about capillaries real quick. So whenever we're looking at capillaries, don't forget capillaries are exchange vessels. Capillaries connect arterioles to venules, right? They connect the arteries to the veins. We got smaller and smaller and smaller in our arteries. Eventually, our smallest arteries are called arterioles, and then our smallest veins are called venules. And so we're going to link the two smallest together with these capillaries. Remember, this is just an endothelial tube. All it is just that inner lining, that tunica intima or tunica interna. And again, this is important for exchange. We've got 3 different types of capillaries. We have continuous capillaries, fenestrated capillaries, and sinusoids. So let's talk about these 3. The first type of capillaries are continuous capillaries. Continuous capillaries are the most common type of capillary. So anytime I'm talking about capillaries in class, I'm basically talking about these continuous capillaries. These are the main capillaries we think about that allow the smaller things in and out, right? Water, nutrients, waste, the basic things that need to be exchanged, but not larger things. We're not going to see proteins really moving in and out. We're not going to see cells moving in and out. So we're going to kind of filter out based on size. So the large things stay in the bloodstream. It only allows the movement of smaller substances. And again, these are the things that tend to keep those cells alive. So we're talking nutrients, we're talking waste, things like that. So these are the main types of types of capillaries. These are called continuous capillaries because these capillaries are made out of tightly packed cells. So these cells are so tightly packed together that they form a continuous lining, right? So they form this continuous lining around the lumen. And so it's almost like a tile floor. Each tile is a cell, but then we take that floor and we roll it up to make a tube, and we've just made this continuous capillary. The only way to get in and out of this capillary is through the cells if you're fat soluble, or between the cells through gaps between the endothelial cells if you are water soluble, which most things that we deal with tend to be water soluble. There are some capillaries that have bigger gaps, right? They've got this same kind of setup, but there's just bigger gaps in between the tiles. So there's spaces in between tiles. This is called a fenestrated capillary. The fenestrated capillaries, fenestra is a German word that means window. So these capillaries have bigger windows in comparison. They've still got this complete lining, but there's just small regions where the endothelium gets thin, and as a result, it starts to make these gaps. And these big gaps, now we can move larger substances. So I want you to understand that. These fenestrations allow us to move things such as plasma proteins. Okay, it's too small of gaps to move our cells in and out of the bloodstream. But here, if we have bigger things like bigger hormones or bigger waste, then or bigger nutrients, right? So small intestines, endocrine glands, these kind of places, we may need to get some bigger things in and out. We know from a previous chapter that plasma proteins are made at the liver. So we're going to see some fenestrated capillaries in the liver that allow those plasma proteins to get into circulation to begin with. Okay, so these are kind of the mid-ground of these capillaries. They've got these windows. They don't have giant gaps. They've just got smaller windows in and out of the blood vessels that allow for faster exchange of larger structures. The biggest openings in a capillary come with our sinusoids. Sinusoids now have an incomplete lining. So what that means is instead of a nice tiled floor, we're missing clusters of tiles. And when we miss clusters of tiles, we don't really have a barrier. So that means things can freely move in and out. This allows the largest substances in and out of the bloodstream and allows things to move quickly. Now, because it allows the largest substances, we're thinking, where do we make these cells? Where do we destroy these cells? So remember, most of our bone cells, our formed elements, are made in the bone marrow. So we're going to see these sinusoids in bone marrow so that the cells can get into circulation to begin with. And then we're going to destroy many of those cells in the liver and the spleen, or store some of them even. And so we're going to have some sinusoids in those areas especially. And sometimes some of our endocrine glands that have the largest hormones may need some of these sinusoids too. Usually if we see a sinusoid, we also have a type of a macrophage or a phagocyte that hangs out there, kind of like a bouncer, right, at a bar. And so if you are a bad guy, if you're a bacteria and you're trying to travel in and out of these regions, then those phagocytes, those immune cells, should be able to eat those bad guys so that they can't cause any damage, can't get in and can't cause damage. So we have to monitor these in order to keep these areas safe. Capillary beds are really just an interconnected group of capillaries, and these interconnected groups of capillaries allow us to spread this blood out to more tissues and hit more tissues at the same time. I don't care if you know the term precapillary sphincter, but the precapillary sphincter is simply just a little muscle towards the beginning of the capillary that kind of controls the flow through that capillary. So this kind of can allow the flow to go in different directions. Here we can kind of see some of those precapillary sphincters, and so we can open and close these to allow certain blood to certain regions. It's kind of like going through downtown Greenville. You know, if you're coming from Pickens and you're trying to get out towards Spartanburg or something, then you can come in 183 and just keep going straight through downtown, and eventually it becomes 185, and then no, 385, excuse me, it becomes 385, and then eventually it hits, the interstate, it hits I-85. But you could also go many different ways. Instead of going through downtown Greenville, you could take a left at Stone Street and go around and hit Lawrence. You could take a right on and go down through River Street and that kind of thing. So this is really kind of the concept, is that we can supply an entire community of cells by controlling which ones of these guys are open and closed. And again, the more active tissues need to get more blood, okay? The whole key is perfusion, right? We've talked about this already. Perfusion is blood per time, right? Usually when we talk about perfusion, we're talking about cardiac output. We're talking about how much blood flow reaches the capillaries at a given amount of time. So perfusion, this is really where it matters, right? This is where we're really measuring it, is how much blood flow flow is getting to these capillaries over a certain amount of time. Now let's head back through the veins, and we're almost finished with this first half of this chapter. Let's head back through the veins. Veins are starting at the smallest, right? At the venules, these are the smallest veins. Just like in the arterioles, as we became smaller, we lost layers. Now in the veins, as we become bigger, we're going to gain layers. So the smallest, these guys still just have an endothelium, the tunica intima, and maybe a little bit of something wrapped around them. But as we become the largest venules, we gain back the other layers. We gain all three tunics back. And so now we're more like our traditional blood vessel with all three layers. The venules merge, and they merge to form some of the smaller veins, and then the smaller veins form medium-sized veins. I want you to know that medium-sized veins are the companion vessels with our muscular arteries. That's a very good thing to know. The muscular medium-sized are connected, and so they're very similar. They're coming away from these organs and these muscles. And then eventually the medium-sized veins are going to merge and form the largest veins. And the largest veins are the ones that tend to be right beside those elastic arteries. That's their companion vessels. And so these tend to be like the superior and inferior vena cava and some of those largest veins coming right back into the heart. Now, as I pointed out in the very beginning on that image, veins have one unique characteristic. They have valves, okay? So veins have valves. And again, the reason that veins have valves is because valves prevent backflow. Whenever we talk about gravity versus pressure, as I mentioned before, that blood pressure must drop as we leave the heart. It has to go down in the arteries, continue dropping in the capillaries, continue dropping in the veins until we get back to the heart. And the problem is that in the veins, we have very low pressure compared to all the rest of the system. So this very low pressure, especially in the lower extremities, like in your feet down at the bottom of your legs, then it can't overcome gravity in order to get back up to your heart. And so we need to have some extra help with that. And so valves are a super important component of kind of compartmentalizing the blood vessel and allowing us simply to move blood up past one valve into another compartment. And so these valves, they prevent backflow and they prevent pooling in the lower limbs. If you stand and you lock your knees, then your leg muscles in your lower legs stop flinching. And what you don't realize is when you don't lock your knees, these muscles, they move more often than you think. And they do these tiny little flinches. And what they do is they squeeze on the veins and they push the blood up above that valve. If you lock your knees, you stop those contractions that you barely feel. And then as a result, the blood pools in the legs. It doesn't head back to the brain. And eventually you're going to pass out whenever you lock your knees and you stand for a long period of time. Okay, it's due to the valve activity. You're not allowing the valves to be active and push that blood. Now, as I mentioned before, the veins are a reservoir. Systemic veins is where we keep most of the blood. It is a blood reservoir. 55% of the blood in the body at any time are in the systemic veins. I don't really care if you know about the rest of these percentages quite as much. I wanted to point out, though, as we mentioned, that lumen is larger. And so it allows it to kind of act as a storage unit, a storage area. And so especially in that systemic circuit, we're going to have most of our blood. Okay, you can see these other percentages. I'm not going to put these on the test, but it's just kind of interesting to see. The heart has 12%, pulmonary circuit only has 18%. The majority, over 2/3, is in the systemic, and over half total of our blood are in those veins. At that point, again, as I mentioned, it acts as a blood reservoir, so we have large amounts of blood that stay here. If we need that blood, we can vasoconstrict and push it back into the system and kind of get more blood flowing through the arteries. But overall, we can kind of reservoir this blood and wait until it's needed to be pumped further. At that point, we're finished with the first part of this presentation. So this was the first half, or a little less than half, a lot less than half of chapter 20. This was the easier information. The more difficult information is coming up in the next presentation, and that's why I split these up. I wanted to go ahead and hit this easy stuff and then go ahead and create one recording of that so that you could watch that separately. And then you could go ahead and start right at the beginning of the harder stuff with the second part of chapter 20's recordings. So be on the lookout for that second part. I'll post that along with the rest of the videos. And again, hopefully you did well on your first lecture test. But if you didn't, now is definitely the time to be studying for this second lecture test. We're in our last chapter here, chapter 20 for this lecture test. So make sure that you're giving your best effort. If you didn't do well in your first test, it's not the end of the world. We still have plenty of time to bring our grades up, but now is the time to bring it up. We don't need to wait till the end when there's not a possibility to bring it up. So I want to see everybody do their best right now. Even if you did well on the first test, I want to see you do better on the second test, just for your own sake, just so you will have the best chance of getting in your program once you leave these classes. All right. So that's it for today. I hope you've enjoyed it. And if you have any questions, please contact me. Have a great day.